Hello everybody, welcome to this afternoon's webinar. We'll be starting shortly. We're just waiting for some of your good selves, the attendees today, the delegates to the webinar, to join our room. So thanks very much for joining us this afternoon. We'll be handing over to your chairs in a moment and my colleague to give you the introductions just in a few seconds time. We're just waiting for you to join us. So thanks very much. And with that in mind, welcome to this afternoon's webinar, and I'm handing over to my colleague Ellie.
Good afternoon, welcome. Thank you ever so much for joining us. It's a real pleasure to have everybody here. I'm Ellie Haworth and I'm Head of Partnerships and Practice Improvement here at SCIE, the Social Care Institute for Excellence. And we're really pleased to be running a series of webinars on behalf of the Department of Health and Social Care, showcasing organisations who are taking great strides towards increasing and improving capacity and capability all across the adult social care system. In our previous webinars, we've looked at lots of different places doing different things, and today's conversation is brought to you as a combination actually from partners from Stoke-on-Trent, Bridgend, and from the organisation YOURmeds as well. And they're going to explain to us how they've used the YOURmeds technology to promote independence for those reliant upon medication to manage long-term conditions. So we're hoping that we're going to see what the beautiful power of common sense and technology can bring us when they work together, making support for all of us within our own homes more and more possible all the time. So I'm looking forward to today's conversation. I'm going to hand you over now to Priti and she will take us through the next stages.
Thanks, Ellie. So today, really, we wanted to have a broad discussion around medication adherence. So I invited, we've got Tom and from Bridgend Council, who is a clinical lead pharmacist in that service. He's working joint between the Health Board and the Council. Lou has also joined us. Initially, Lou was at Bridgend Council, but she's now a project manager at the Life Sciences Hub, helping to support the YOURmeds programme. Peter is multitasking today, so he's currently in another meeting, but he'll be rushing back in here at some point. And Pete's from Stoke-on-Trent Council, in charge of the Telecare and rehab services. And then my name's Priti Patel, and I'm head of sales at YOURmeds. A little bit of housekeeping. We really want this to be a sort of an interactive discussion. So if you have got any questions, please put them in the question box. And we're also going to be running some polls as well, just so that we can. I've got some burning questions that I've been wanting to ask a lot of people at once. So this allows me that opportunity to ask some of those questions. So why we're here really, it's to have that wider discussion around medication adherence from an adult social care point of view. I wanted to, a lot of people ask me how other councils are doing medication adherence, so I thought it was a great opportunity to get two of our partners to come and actually talk, and that way you can also ask questions directly. The World Health Organization and the NHS widely recognises that only 50% of people take their medication as intended. It's known that actually improving adherence would have a better improved health outcomes more than any technological advancement that you could have. So we know the medication's there. We know that if we can get people to take the right medication at the right time, we would improve health outcomes and importantly increase people's independence, allow them to stay in their homes for longer. One of the stats that I always use is that someone who's prescribed a statin, after 2 years, only 30% of those people actually take that statin correctly. So I think there's a huge sort of impact we can have around medication adherence, which would have benefits across the system. And the inceptions of the ICB and the ICSs allows us to have that joined up conversation around adherence and almost just approach it with a fresh pair of eyes and say, let's look at all the issues within the system and try and join them up together, because we've got some really clever bits of tech that we could use to simplify processes and increase capacity and improve efficiencies, like Ellie said. So I know Bridgend Council have been on a journey to try and join up this conversation around medication adherence. So I'm going to let Lou and Tom talk about how they what they saw around medication adherence, why they thought it was important to address.
Do you want to go first, Tom?
Yeah, of course. Yeah. So yeah, as Priti mentioned, we know that lots of people don't take the meds as prescribed. That obviously contributes to, I think it's around £300 million worth of waste from medications in the UK. But not only that, the health and well-being impacts that has on the individuals that we've seen. So I'm sure you've all in services come across people that aren't managing their meds very well, and that can lead to a prescribing cascade. So it may be that they prescribe more medication because the clinician thinks that medicine's not having an effect, and then we see people on multiple medicines, and maybe that's not always appropriate. So yeah, in Bridgend, it was a real issue for us with how we support those people to take their meds, and how do we continue to ensure that they are able to supported with their meds and they're continuing to take them correctly. So Lou, I don't know if you want to come in with kind of where we were in Bridgend when we first started.
Yeah, so for a long time in my previous role, when I was in Bridgend, that I supported and was responsible for the Telecare and tech services, so extensions of exploring new options, but also trying to keep people safe at home for longer with the Telecare services that we had in place. In Bridgend, we've got quite a large Telecare service and a mobile responder service that's supported 24/7. The biggest problem that I found historically over a long period of time was that medication reminder prompts on Lifeline units or Patel or similar kind of devices were being requested by social workers as part of discharge packages because we didn't provide meds only calls. It just isn't feasible. It's not something that Bridgend does. And often what we would find is that from a tech services point of view, I set up a list of questions that we would try to ask to make sure that these were being supported in the right way. But ultimately, the only questions we could ask is there someone who could fill that device, and is there someone who's going to take responsibility if anything happens with that device, like it jams, so that the care and repair services engineers would have somebody with them because they can't touch the medication. And we would always get yes answers because people wanted to be discharged from hospitals. What we would find is often that families weren't able to support that, engineers would be called out, and then we're in a problem where they couldn't touch the medication. Or the devices weren't even being used at all and were forgotten about and lost, which was quite an expensive resource then that was being used in the wrong way. As tech services, I didn't have the skills to be able to do the things that Tom does because I don't understand medication. I understand tech, but I don't really know what's appropriate, whether it's being put in the right times and what should happen. So it was a big problem because none of them ever worked in the right way or not in the way that they were intended. And the risk was always, how do we manage that? How do we police that? How do we know if what we're being told is right? Because there's only a certain number of questions we could ask. So I went to Tom and said, we really need to join forces on this because you've got the pharmacy skills, I've got the tech skills, I can tech your team up, I can give them those skills to know how to assess for the right piece of equipment, what to ask and how to do that. But I can't do the magic that you do when it comes to working out what meds people are on and the way that they should be taking them. So the approach we took was very much an integrated approach, because without that, I think it wasn't really marrying in the right way, and we clearly saw that in the way that we'd been working up until that point. And when we started to pick apart how the best of both teams could come together, we realised that actually this is a really untapped resource of way to work, and how different the outcomes could be, not only for staff being able to apply more solutions to the problems, but actually outcomes for families and the individuals themselves was far more stringent and reliable than it had been when we were doing things individually in silos.
That's great. Did you do some research around the wider system impacts of medication adherence as well?
So,
because I was sort of, I was speaking to a commissioner the other day, and they were saying that within the police, mental health sort of incidences around the police, they said half of those were due to non-compliance around medication. So it's kind of, you know, medication is kind of really far-reaching, I think, across not just health and social care, but right across the wider system. So I just wondered Lou, and Tom, whether you've just done it, if you've done any work around a whole system approach.
We've done some looking into the research papers that are showing that non-adherence, obviously within the health and social care context, and that can contribute to around 5 to 10% of hospital admissions, and we see that number increase for the over 65s, which is primarily the people we're seeing in our services. And we've seen within our own services that actually recently we've got people that we've been able to improve their medication adherence, and we've had somebody who thought that they had undiagnosed dementia, and actually by them taking the medication correctly, their mood has improved because of their depression, and consequently we've actually seen now that they're not forgetting so much, they're far more independent with all the other parts of their daily life as well. So yeah, I think working in an integrated team, we can see the benefits of if we can actually get some of the basics right, so things like medication, nutrition, those kind of things, the fundamentals that we all need. If we get them right, then we can really work with these people, and then we can start seeing real benefits from physios, OTs, and we can really kind of get the most out of these people when we're working with them as an integrated service.
Okay, that's great.
Some of the things that we were seeing were, like Tom was sort of saying, was Parkinson's patients, so with increased falls, coming into the acute clinical nursing team, then it was seen as a bigger picture, but actually what we were drilling it down to was, well, were they taking their medication at the correct times? Were some of these other things that were happening as a result of that medication? And it was a common factor that I had come across prior to us starting this project, which was a big discussion point that Tom and I had. It was quite a meaningful case that I remember from a long time ago, where a gent was falling quite a lot, but because he had Parkinson's, it was deemed, well, oh, well, it was just part of his condition and you should expect that. And he was worried that he was going to end up being put into residential care, which wasn't necessarily the case. And when we started breaking it down and working with him, there was queries around whether he was taking his meds. Family thought he wasn't. He was saying he was. Well, he was, but he just wasn't taking it all at the right time because he was falling asleep. So when we got him onto a better pattern of, well, a reminder prompt will set that off so that you'll be better with the meds via a clock device that we provided him, really simple. Actually, his falls decreased because he was more regimented with taking his medication. So whilst he was doing it, it wasn't the right times, which was then causing a lot of the other things that were happening. So where he and his family were having discussions about, well, you can't live independently in the community anymore, you might need to go into residential setting. Actually, he didn't need that. All we needed to do was get his meds right, and all of those other things improved for him, which could have been quite a different story if we hadn't started picking it apart and looking at the fundamentals.
Yeah. Yeah, and it's that whole joined up approach really around it. I'm just briefly going to just talk about the YOURmeds system, and just, if people aren't familiar with it, just sort of hold the device up so that you can tell what it is. So this is YOURmeds. It's a smart medication management system. When it's time for you to take your medication, I've just punched it because it started beeping at me. A number comes up on the screen. Oh, my camera's all the wrong way around. And an individual basically matches the number to the screen. The packs are filled and dispensed by the pharmacy. So within Tom's service, we're placing 4 of these packs on a 28-day prescription, and the user just slots a new pack in every week, and then basically it's good to go. It will inform them when to take the right medication at the right time. If they don't take their medication, then they can inform a network of supporters around that individual, so they can nominate up to 5 people, and those supporters are informed through the supporter app, which is linked to the pack, and the supporter app shows which medication was due yesterday, today and tomorrow, and they can see the medication going through in real time. All of that data is then collected into a central dashboard, and there you can download reports and audit reports on an individual's medication and when the notifications were sent to the supporters. So you've got that full audit trail of what's been going on in real time in that individual's home. You can also see the pack in real time, and we're currently working on creating a carer dashboard so that we can actually see multiple number of people at once and actually identify those who are struggling, who will be in the red zone, and we know that we need to do something for those individuals as opposed to the people who are happily taking their meds on time in the green zone. So I think the difference really around sort of YOURmeds is trying to increase the capacity and improve the efficiencies within the system. So the other day we supported someone being discharged from hospital in Manchester, went to see him on the Thursday, and the meds piece was the one bit that they were struggling with, and to try and find a carer to support around the meds. Fortuitously, a family member decided to step in and become the supporter, so then it was just a matter of the meds piece. Otherwise, that individual was looking at another week in hospital, really, to try and find that care package of support. But we managed to get him out of hospital and into his own home on the Friday, with support from the health and social care team, which was really great to see, like that joined up working and thinking. So I'm just wanted to ask Tom and Lou really how they're looking, because they've just started the YOURmeds project, and how they're looking to use YOURmeds within their service.
Yeah, so we've recently started on a pilot within Bridgend. So we are in the phase of rolling out to people. So we're looking at various groups. So we're looking at up to 40 users to kind of pilot and see what value we can get from using kind of a remote monitoring medicines management system. So we're looking primarily at people that maybe don't qualify for social care, or people that are on a waiting list for waiting care, because we all know that there's capacity issues within the care system at the minute. People that are with a mild to moderate cognitive impairment, as well as people being admitted to A&E or AMEU in our local hospital due to medicines mismanagement issues. So we've recently had somebody that's been admitted to A&E and has been struggling with the medications. They were needing extra support, and it turned out that somebody was charging this person who can't read or write to support them with their medications, but was charging them quite an obscene amount of money every day. So really kind of person at risk being taken advantage of. So we were able to use the YOURmeds device for that person to get them out of hospital quicker, so they're not sitting in A&E waiting for a support package that might not necessarily be needed. So yeah, we're looking at a varying group of people. We've got family that are going to be part of that responder circle, but we've also linked up within Telecare services our alarm receiving centre. So we've got our final responder will always be our alarm receiving centre, and where people are uncontactable, where we can't get hold of the family responders, we can't get hold of the individual themselves, then we've got our mobile response team within Bridgend that we can kind of send out, do a welfare check, and make sure that that person's safe.
Right. I've just realised I forgot to do my polls. So I'm gonna do the first poll, which I hope we will see on the screen in a minute.
Wait, give me one sec. Okay, here we are. I'm just going to share that.
So the first
Hopefully you
poll
can see
is,
that.
yeah, first poll is medication management a health or social care problem, or both? I feel like I might already know the answer to that, but it's always interesting to ask the question, isn't it? When people, when I go around the country talking to the adult social care teams, it's interesting the response I get to that question. So I thought I'd throw it out to the 110 people who have joined us today.
So let me launch that now. I'll launch the poll now.
Right.
And just wait for some results to come in there. From the start, the majority is saying both. So
Yeah.
it's roughly 10% saying health and 90 are saying both. In fact, 11. Yeah, about 10% are saying health, 90% are saying both. So I'll just close that poll now.
Okay, and then I might just do the second poll as well, because as we're talking around how Bridgend is supporting medication, so what percentage of care packages have a medication support component? So 25%, 50%, 75%, 100%. So out of the care packages that you support, how many of them have a medication support component?
Thanks, Priti. I'll just share that poll now, and that'll be Oh, sorry. No, I think that's the wrong one we shared there. Hang on a sec. Here we go. Let's do it properly. There we go. So there's a clear favourite again, but more distributed. So we'll just wait a little bit more. A lot are saying 75%. So at the moment, it's 9% are saying 25%. If this makes sense, 14% are saying 50%. 74% are saying 75%, and 3% are saying 100%. I've never said it before, that 74% are saying 75%, but the vast majority, yeah,
We know
the
what you
vast
mean.
majority, 3/4 are saying are saying 75%. So there we go.
That surprises me. I don't know. Does it surprise?
Yeah. And 14%. The next one after that is 14% are saying roughly half. You know, so the vast majority are saying that they think it's 75%. I'll now close that one, and if we're not doing any more polls for the moment, I will stop sharing the screen.
Yeah, that's fine. Does that surprise you, Lou, that it's 75%?
No, it doesn't. A few years ago, it probably would have surprised me, but I think post-COVID, you're seeing that more people need more support because people have deconditioned, things have changed, and the landscape of health and social care is so not anywhere where it was before. It's still a great place to work and a great, but there are so many challenges now, and carers in the community are struggling, and medication is one thing that I think a lot of families, being a carer myself, it's one of the things that I always get nervous about doing, because I don't always have the skills, or I'm not always able to be there at the right time when something needs to be taken. So if there is the capacity, I think from a social work perspective, often if you know you're going to need to set up a care package for something else, and there's that potential that medication could be needed to be supported, whether it's now and again or all the time, I think sometimes people do err on the side of caution and add that in because it's so hard to get increased care calls. If you're going to do it, add it in from the beginning. Is often the view, whether that's right or wrong is not for me to say, but that is often the view that I think people take, because if you send somebody home and then they need an increased package for that, it's just so difficult to get. And if somebody's going in, it's not much different to prompt some medication, whether that's from a Dosset box or blister pack or something else. But it clearly shows to me that there's a definite demand for medication support, and it isn't being managed as well as it could be, unless you're leaning on social care as a way to do that. And how sustainable is that in the landscape we're working in now?
Yeah, with you've got the workforce elements as well, the reduced amount of workforce, and then interestingly, yesterday I had a conversation within Sheffield, and they said that we need to make sure that people understand the difference between someone that requires a prompt and someone that requires an administration, because that's two very different things. And I think it's the first time I've heard it that clearly before, that actually should we be prompting more rather than automatically saying it's an administer? And is that how, because one of the biggest challenges we find is that it's trying to do that change management piece around the workforce, because you've always commissioned a care package, an actual physical visit, and then to say to people or social care assessors or just the social care workforce that now it's a digital prompt, and how do you sort of overcome those issues, and how do you do that training? So I think it's, and yesterday hearing that sort of we need to get people to recognise the difference between a prompt and an administrator was something that I went, oh, okay, that's something I can actually hinge some proper learning around, to sort of to say, well, maybe we prompt first, and then and that's what I think that is what Stoke-on-Trent do basically, is that I was hoping Peter would have arrived by now, but is that they use the medication device. So Peter will say that as a medication device, it's as simple as it can be. So if someone can't take their medication through the YOURmeds system, then that gives them the evidence then to have put in that care and that actual physical visit, rather than providing it as a digital prompt. I'm just going to ask again, if anybody wants to ask any questions, please feel free to put them into the question box as well. So in terms
We've had a couple come in, so I will put them across to you guys. Thank you very much, James and Diana.
And then it's really so about the supporter network, and hopefully Peter will come and we can catch Peter up in this webinar. The supporter network, how important do you think the supporter network is around medication? So, Lou, you said already that you're supporting your mum.
Hello.
So
yeah, I think the supporter network's key, really, isn't it? So in Bridgend, we're using that supporter network to really give the individual maybe a slight prompt if they've forgotten to take their medicines, and they're managing that. But then our service is kind of constantly reviewing that dashboard for those with the higher level of need, so the ones that are possibly taking the wrong medication. That's something we would want to get more involved with, because then there's more of a clinical question of, does that person need to kind of change their next medication prompt? Do we need to change that? Do we need to have any sort of other clinical involvement with them doing that? And likewise, if they're constantly or repeatedly taking the wrong medication or getting confused with it, then that's a great opportunity for us to bring services back in. So I think that's where that remote monitoring really comes into its own, is with things like blister packs or alarm clocks that maybe prompt that individual, where we've got no oversight of when things maybe start going wrong. So that might be because there's a change in their cognitive impairment, or they may have an acute UTI, they've got a water infection, they're a bit confused and they need a bit of support. So we're able to really direct our services to those that really need it when they need it.
right.
Yeah, I agree with Tom. That was one of the biggest things for us, was making sure that we created a proactive and preventative model that was about meds, but also about individuals, and trying to pick up on things that were changing. So does Mrs. Jones always take her meds on time and then suddenly stops taking lunchtime meds? And why is that? And is it sporadic? So is there something that's happening, or is it something that's happening to her in terms of her conditions or well-being that's causing that? So we can get in there earlier to stop UTIs or hospital admissions or falls or other things happening. So what incidental data were we seeing from what we were doing? And even early stage pilot, we've already picked up on things where some of the reason people haven't taken meds at one day is because they're ill in bed and they haven't been able to get up because something's happened, or they've had a fall, and that's then we're picking up incidental things that we weren't necessarily thinking we would see as often as we are seeing. So that's quite an interesting concept to us, because it's that other data or other things that we're seeing that now we need to consider. That's actually another benefit of what we're doing.
Right. So good to hear. Peter, I'm going to let you do some talking now.
Steve again from SCIE, just to say, we do have a few questions now lined up. Put them into the area I told you about earlier. So that while Peter's talking, you can consider those, I'm sure.
Okay, great, thank you. So Pete, do you want to just tell us how Stoke has been using the YOURmeds system?
Okay, starting with two apologies. Firstly, I'm sorry I'm joining late. I was actually in a digital transformation board. And secondly, apologies that I'm working on a very slow Wi-Fi connection, so mostly you'll just see me as a frozen picture. I'm not a frozen picture, I am an actual person, but hopefully you can still hear what I say, even if I appear to be just blanking you all. My name is Peter Ball. I'm a service manager in Stoke-on-Trent Adult Social Care. We've always had a medication reminder prompting system as part of our Telecare and Lifeline service, historically using other technologies. It's not a high use in social care for us. It's less than 100 clients, but it's very important for those clients for whom it's necessary. That system worked, but we had to change for a number of reasons. Firstly, the technology we were using was a bit old and had some limitations. But more importantly, it wasn't pharmacy friendly. It was a technology that's quite slow for pharmacists to fill, which meant we would struggle to get pharmacists to use the digital tech, which defeats the object. So we looked at the alternatives, and YOURmeds was one of the best on the market at that point for how it looked, how it seemed to work. I rolled it out across all of our social work teams, across all disciplines, mental health, learning disability, older people, younger adults with physical disability. And we rolled it out by training each of the social work teams individually so that people get a chance to see the technology, play with the technology, know what I'm on about when I talk about YOURmeds. And we were also able to roll out at that point what is a very simple referral process. It's a single form that the social worker fills in, sends off to the YOURmeds email address, and then the YOURmeds company does everything else. Since it was bought in, our growth in use of YOURmeds has been steady, and it's continuing to increase. I've currently got around 20 to 30 people using YOURmeds, and that's about what I'd expect. Over time, I expect that to increase to about 50 to 60, but I wouldn't expect it to go higher because it's not generally a social care demand. I think that for me, it's gone very well, and I've been very pleased with it, but the key learning from this has been a need for sort of flexible and innovative support planning. So I can't just provide the technology and my social work colleagues just use it, because we seldom do home care calls that are just for medication prompts, for instance. So that the medication prompt technology only works if you combine it with thinking differently about how you put a package together. So instead of a package being going to do a lunchtime medication prompt and preparing someone's meal, you can replace the meal prep with one of the multitude of healthy eating options that can be delivered now, and with a YOURmeds system, therefore saving a home care call for the person who actually needs it more. I think you need it to be a simple system. As I said, this is a very simple system for us. It's a single referral form. You have to make it very easy for social workers to get the service and very easy for people to get the service. One of the key things for me in a successful take-up of such a system as YOURmeds has been the importance of a contact of last resort. For us, as I'm sure Priti has explained how YOURmeds works, you can have up to 5 contacts. But for us, most of the people we're putting this service in for, by definition, haven't got anybody who can be a contact, because if they did, they would just prompt them. So we've been using our in-house Lifeline team, the team that answers the activations when a community alarm goes off. They're there 24/7, and they receive an alert if the person doesn't take their meds, if that person hasn't got any other contact who could do it for them. That's at least half, and probably nearer to 80–90% of the people we've got on the service now can only be on because we have that contact of last resort. The last thing that, as a learning point for me, is that the use of the analytics has been more than I'd expected. I'd hoped that the dashboard information would be used by my colleagues, but I've been pleasantly surprised with just how much it's been used in order to see the level of compliance and the improvement or poorer level of compliance that's happened over time. It's also in some cases helped us to identify when a problem has started to develop. We don't monitor it on a daily basis, so it's not an alerting tool, but for people for whom we want to keep an eye on things, that data analytics allows us to see things are starting to go awry so that we can deal with it there and then. The last thing I will talk about is just our next steps. we've been promoting it to pharmacy colleagues in Stoke-on-Trent so that they can signpost people to social care or to self-fund. I hope eventually that this is something that we can use across the health and social care economy in Stoke. We're also promoting it to home care agencies. I want to set up a trusted assessor process by which home care agencies can identify people who don't need medication calls, and we can put a YOURmeds in place and support them in the meantime. Thank you all for listening.
That's great, thanks, Pete. So there are some questions in the chat around prompting versus administration and how that fits in the CQC. Have you guys got any thoughts on how you've addressed that? Do you perceive a difference?
There's always historically, from a social care perspective, been that difference as to what is prompting, what is administering, what care staff can do, what they can't do in terms of the care council. So it's always been a tricky one. But I mean, the device itself is obviously prompting people to administer their medication safely. I think that it is a fine line, it is a difficult one, and it isn't easy to work out the logistics of it. But I suppose for me, it's far better to apply a device such as this to somebody's daily routine to give them self-dependent nature to do that, you know, rather than a care staff coming in. You do personal care, you're doing breakfast, you're doing lunch or whatever, and it's like, well, take these now and take these, but are they fully in control of that? Is it just a case of that gets put in front of me, I pop it out, or it's in a box or a cup and I just swig it down and I'm not really in control of what's happening or fully understanding that? I think by giving a device such as YOURmeds, what we found is people are engaging with it a lot more and are starting to take responsibility and ask more questions about, I'm taking this and why am I doing that? This is for this, that is for that, and starting to become more involved in their own medication regime, which in terms of prompting or administrating via social care a visit isn't the case, because it just becomes the norm. And I think we kind of de-skill people by doing that, whereas what we're hoping to do is upskill or keep skills, you know, which is really important.
Yeah, keeping people independent, isn't it? It's just giving them their independence back, rather than so one of the questions also is like, have you considered using a video screen technology to assist rather than responders to check meds taken? And I get asked this quite a lot. So by giving people that ownership of around their own medication, you're actually able to then use it as a cognitive assessment tool. If you're phoning them up and saying, or watching them and saying, right now you need to take your meds, you've taken away some of that insight that you might have got if they do it independently. But I'm not saying that it's not right for everybody. I mean, you know, YOURmeds is one of the tools along that runway, really, of support. So you might go further down the runway and go, actually, now they need that video prompting and that additional support. But I think there's probably a space before that where you can use YOURmeds and allow that individual to have that independence that you spoke about, Lou, and trying to keep them, to give them that independence completely within their own homes and keep them independent in their own homes for longer rather than within a more supported environment. Coming back to my questions, you've done the supported network. So in terms of when you were trying to introduce YOURmeds into this adult social care team, because they've been used to providing a physical visit, how did you do the change management piece around thinking digital first? Because that I know that it took us a while, didn't it, to sort of get there, and you ended up having to put a resource in. So I just wondered if you could explain around some of that there.
Of course, yes, and I would say that we're on a journey rather than having reached a destination there. To start with, we started by promoting the technology and the reasons behind it. I think it's important to recognise that YOURmeds isn't a replacement for home care where home care is needed. It's a replacement for home care where home care isn't needed. So we were able to point out to my other social work colleagues that if you use a 15-minute call here, somebody somewhere else isn't having a 15-minute call. So let's use the technology where the technology can work. A second thing that's really helped is that we have an authorization system whereby, as managers, we screen what packages are put in place, not in order to overrule the social worker, but to identify if perhaps they could have thought of something else. And I was able to use that, I'll call it a panel process, but it isn't a panel process. I was able to use that panel process to identify in specific cases, this person could have had a YOURmeds, this person could have had other technology. And that allows us then to deal with individuals who haven't yet got their head around the use of it. And that's not a judgment on them. This is new and scary. And those two things together, plus a lot of promotional work with individuals in teams when they come to me and ask for ideas, has allowed us to at least get people thinking technology first, so that they will come and discuss with me before trying a dom care option. And that's worked well. I mean, going back to a previous question that you dealt with around medication prompts versus administration, something that I've used with social workers, and people quite rightly come with me on this, is that the use of something like YOURmeds is actually safer. Using any sort of medication prompting administration by home care is putting another step in the process. So a YOURmeds being loaded by a pharmacist and then the person is the next person to open that pack means that there's one less step in the process for something to have gone wrong. And basically, it's things like that. It is appealing to the common sense of the people that I work with.
Great. Should we do another poll? Feels like it's time for another poll. So the next, let's get the polls up. I think we've wrote this one down. So this is the question: do you work with health colleagues to support medication in the community at the moment? It's a quite simple yes/no answer, which will probably lead me on to sort of that discussion really going forward in terms of working with the ICB. And I know Bridget are already doing that sort of joint working piece. But if either of you wants to really talk about what sort of things you're looking at going forward in terms of a preventative agenda around sort of supporting people.
Okay, so shall I launch this one, Priti?
Yeah, if you launch that one.
Here we go, and that's been launched. So it's a straight yes or no. To start off with, it's sort of looking about 60% yes and 40% no. We're just going to let that settle down a bit because it's becoming more. Well, it was changed. Yeah. Oh, it's gone to exactly 50% yes and 50% no. We've never had that before.
Excellent.
A straight tie, 50%. So I'll close that one. There's always there's always firsts, and this is a first. A straight tie, 50%, 50% on one of our poll questions. Fantastic.
So really throwing it back at you guys then. Are you? Oh, there's a second part to this question. So are medication only visits commissioned? I know some places that within adult social care teams, they don't do med only. And I know, Lou, you mentioned earlier that there was no med only. And like I said, I'm really nosy and I've got an audience of over 100 people here. So I was going to ask the question, are med only visits commissioned? So should we do this poll as well?
So,
and then we'll talk
yeah, let's launch this one. We'll launch this one and launching that one now. And let's just wait for those results to come in. Sort of starts off 60% no, 40% yes, and it's heading more towards the nose actually. So I think almost done on that one. We're kind of looking at 67% a no and 69% no and 31% a yes on that one. I'll close that poll. Thanks so much. We've got one more poll after this, but we'll do that later.
Yeah, in a minute, I think. I think it's interesting how different it is across the UK in terms of how meds has been sort of managed, and that always surprises me in terms of how everyone does it so differently. And I just wondered, with the ICSs and ICB, what your plans are really going forward with health, and how do you see that joined up working coming into play in the next sort of, I don't know, 12 to 18 months. Priti, do you want to go first? And then we'll talk to
for me, very keen to join up with health partners over this. We've done some good work with health partners with other elements of digital technology. And where there is synergy, it's great to use the same systems. My hope is that within 12-18 months, we have at least agreement to be trying this out with some of our high intensity teams in health who are dealing with revolving door clients. I don't like to use that term, but the people who are forever going into GPs, who are forever going into A&E. I'm keen to try out such a process or system with them to see how it will work. And I'm also keen to identify how we can work with pharmacists. I'm showing this stuff to pharmacists. I'm keen to identify how we can work with pharmacist partners to ensure that people are getting this if this is going to be the right option.
That's great. Lou or Tom?
Yeah, I mean, we're lucky in Bridgend. We're a fully integrated service already, so I'm actually funded by health and social care. So we are surrounded by social workers, dietitians, OTs, physios, the lot. You name them, we've got them. And I think that's really important, because it's not just social workers that are identifying this meds issues, it's OTs, it's physios, because actually they're having difficulty working with an individual because they're not taking their pain relief, say, for an example of a physio. And we've got emotional wellbeing support workers, so they're helping support people with diagnosis of dementia, getting them out into the community and getting their medication right, getting it taken correctly and on time is all kind of core to all of that, really. So yeah, integration for me is kind of the foundation of it all. We've all got different expertise. We're in Bridgend, the health board has commissioned for community pharmacies to review and fill these packs ongoing, and we've got the side of social services where they're able to identify and refer some people into the service, but also we've got Telecare services to kind of support with that ongoing management. So like I mentioned earlier, we've got the alarm receiving centre to really kind of be that backstop for those individuals that are either forgetting to take their meds or taking their wrong medication. So I think we're only stronger if we work together, because at the end of the day, we've all got the same goal, and that's the individuals that we see on a day-to-day basis, to support them to be as well and as independent in their own homes as they possibly can be. And by working together, surely that will be easier to achieve.
And from my perspective, being in the hub, the good thing is that the integrated methods of working and the benefits of that, I'm able to try and help Tom to support that idea of integration and how we can make people's journeys with their medication adherence much stronger if we link the dots. And the idea is to use this project as a blueprint then to potentially share that journey and roll out across Wales. Or look at how a similar model could be implemented where there's other local authorities and households that are struggling with exactly the same things, but bringing them together.
One of the questions was just asking for, the question for Jen was, who's providing the oversight of the adherence? Is it the pharmacies, or have you effectively employed someone to fill this role within the tech team?
So within Bridgend, we have a pharmacy team, so I've got a team of pharmacy technicians that go out to see these people, and we'll try and employ a number of solutions to try and keep these people independent. But they'll be assessed by the pharmacy technician as that they could probably benefit from the YOURmeds device. We're worried that at some point in the near future they're possibly going to be struggling with any other sort of medication management. We want to keep a close eye. So we'll identify those people, we'll set it up as a trial period, and then we'll hand over to community pharmacies that are then commissioned to fill them ongoing.
Buzzing noise. I don't know if anyone else can hear the buzzing noise. It's getting louder. It was very faint in the beginning, and now it's definitely trying to take part.
It's not me buzzing. That's all I can assure you. I'm sitting here quiet.
Interrupting things. There is a question around what councils are also using YOURmeds, so I'm going to quickly answer that one. So we're working with a number of councils across the UK. Up in the northeast, we've got South Tyneside, Gateshead, Manchester as well, and Wigan, Staffordshire and Stoke, and I've got a full list. So if you want to get in touch, my brain's gone. If you want to get in touch, then please do. Apologies to all the councils I missed out because my brain is gone. And then Naomi's asked, is there a way for YOURmeds to be used for those who need to take medication more than once a day? So Naomi, this is a weekly solution for. So it's 4 times a day, 7 days a week. If you've got more than 4 rounds a day, like within some of the Parkinson's patients that we support, we just give them 2 packs. So then they'd have a morning pack and an evening pack, and then the numbers run sequentially. So they would just run across the day. So that's how that works. Right, we have a little bit more time. So I don't know if there's anything that you guys wanted to talk about specifically, but it was really around, our next question was that we've talked about the preventative solutions within the ICB and how you're looking to work more jointly around that. But then how can we make sort of medication adherence more of a priority across health and social care? Because it just feels like it kind of doesn't get addressed properly. It's sort of, it's everyone glosses over it kind of, but no one's really prioritizing it and saying, actually, we could solve quite a lot of these issues if we just looked at adherence as an issue and had a more joined up approach around it. And I just wondered if you'd had any thoughts and ideas on how you could sort of elevate the issues around adherence.
I think events like this do really help because it gets people thinking. We all know that it's a problem, but it's almost like the problem no one wants to talk about because it's too difficult to solve. How you do that, and how do you get everybody that you need to get together to make the solutions that you try successful? So that joined up thinking, you know, how often have people tried to do things but it's not worked in the way they anticipated it? Me being exactly one of those people, I can hold my hands up, guilty as that in the past. But I think it is about solutions, about looking to other people's experiences, and it is about thinking about how can you apply that to where you are and your teams and your services. But I think for those of us that are doing it, it is about telling people and being honest about how hard it is, a journey to go on, but how rewarding it is when you get that one case that you've made a difference, or that one family that you've, you know, helped to prove to them that somebody is able to do this, and seeing them say, you know, I can do this by myself now. And it's those little wins that actually make that whole journey worthwhile. But it is celebrating those successes and, you know, talking about the good, the bad and the ugly of journeys and projects and how difficult it is to get there, you know, to make people think, well, actually, we could do that and we could learn from them, and for us being willing to spend our time doing things like this.
Yeah, no, that's great. And I do think it's sharing those learnings really. And part of a lot of what I do is sort of trying to connect council. And poor Pete gets bombarded by me saying, please will you talk to this council, because they just want to speak to someone who's already been through that process and has experienced, you know, the pitfalls and the successes as well around that. There's a question around cost. So the cost of the device is £680 a year, and then it's £10 a week thereafter. So it's run on a subscription model, and we can build you up some pricing should you wish to do something. And then I've got a question from Barney, says, how does it work if a service user pack malfunctions, and how quickly would an issue be resolved? So we would keep emergency packs or backup packs at the pharmacy, so they just need to take it back to the pharmacy and get it swapped out, and the pharmacy will be able to support around that. But even if that's the case, if the pharmacy doesn't, for instance, have any backup, then we can do a next day delivery, so we can get a new tag and pack sent to them, and then it would just be a matter of changing the medication packs across to the new pack. I could do my last poll, I think.
So yes, just share the screen. We've done that one. Okay, here's the last one.
How important is supporting people with their medication in your council? So currently, how important is that seen with a scale of 1 to 5, with 1 being high and 5 being low?
So just launch that one now. So it's 1 to 5. 1 is high and 5 is low. Is that correct, Priti? Yeah. Here we go. Yes. Oh, someone's shaking their head. No.
1 is high.
1 is high. 5 is low. I'm
Yeah.
glad we sorted that out. Here we go.
Maybe I should just done high, low, medium.
Immediately, number 1 is popular, but now it's the no's not so popular, but it's sort of 35%, 34%, 24%, that sort of thing. So roughly a third for 1 and 2. So 33%, 33%, 22%, and then the other 2 aren't really scoring. So is that helpful?
So yeah, pretty high. I mean, it's obviously a pressing issue.
I'll close that now.
Thank you. I'm trying to mute myself. So are there any other points or comments that you guys wanted to make around just generally about adherence, and any other nuggets of wisdom that you might offer someone who's starting to look at medication adherence and going, okay, well, where do I start? You know, where should people start to think, how can we help everyone out there who's possibly thinking about this?
Yeah, I think we've already touched on that. It is difficult, so probably go in knowing that it's difficult. If you're prepared, then you're probably more likely to succeed. And involve other people around you, so find out what other teams are available to bring it together and work together on it, than trying to solve it on your own, because it's a big problem to try and fix as one person, I think. So yeah, I think that would be my key, to talk to as many people in your organisation, because somebody is probably interested in coming on that journey with you, and it's just finding that person sometimes.
And I would say that if you go into this knowing that medication compliance is an issue, and knowing why medication compliance is an issue, helps a lot. You're able to deal a lot better with challenges if you're able to say the impact of medication non-compliance is this many people going into hospital who don't need it, this many people having home care who didn't otherwise need it. I think that enables you much more easily to combat people who might be resistant.
And I think for me, I kind of, you know, it's having that plan and trying to build those early case studies as well, and then doing that re-engagement almost again, because as soon as you've got I always try and get a case study with a local accent. I think it helps if you've got a local accent talking about, you know, how this has helped us in Stoke, for instance, and then trying to sort of help people understand how once they've got that referral to us, that we basically manage that whole process for them. So, you know, it's a matter of just letting us sort of get on with it, and then they have access to the dashboard, and then they'll get access to the monitoring as well. So it's really just about trying to we very much believe in helping you co-produce this. So we're happy to engage with training online, and again face-to-face as well, and we'll support on the ground. So because we recognise that, you know, it's not as easy as it seems in terms of the digital tech piece is probably the easiest bit, but then it's the workforce change management bit is often the harder chestnut to crack. But we're happy to engage with that at all levels, really, when we start a project. Ellie, did you want to say anything?
Yeah, thank you. I mean, I'll do our proper thank yous and goodbyes in just a moment. I've been scribbling questions as we go, but I think you probably answered them all. So I'm going to go through what I thought the questions were. So first of all, I thought, oh, is this something that's scalable? Is this something that can happen all sorts of everywhere for every people? And I think you've been telling me that if you've got the right networks and you've got the right communities and professional groupings, then this is scalable and, you know, can be delivered for every place. I hope I've got that right. You're all nodding at me. Yes, I've been listening. Brilliant. And I've been hearing about who needs to be part of these partnerships. So it really does sound like it's collaborative with a number of different groups. That it could be the pharmacists, it could be the social care groups, it could be the health providers, it can be the families and the individuals themselves, and there's a whole bunch of people who are going to be involved. So it does sound like it's got all those high quality markers of partnership and collaboration that we are so keen on. So again, I'm hoping for the same set of nods that I'm right about the partnership elements. And as I've been listening to you talk, I've been thinking about who are the particular groups of people. You've talked about people with specific conditions, you've talked about people in specific circumstances, you know, discharged from hospital, or and I'm just thinking there are so many connections I'd like to make around, you know, does this have a role in transition to adulthood for perhaps people who've been, oh, I'm getting a lovely nod there from Louise, so I clearly hit something on the head there. And I'm thinking about virtual wards as well, and whether there's, oh, look, at the nod rate is going up as I talk. This is wonderful. And then the three final points that really made me, that I really learned from listening to yourselves, was about a strengths-based approach, a co-productive approach, and a diversity approach, where, you know, this isn't about minimizing the individual's role. This is about hearing from them how this would like to be managed, maximizing for the greatest possible time their control and role. And, you know, kind of this can be adapted and should be adapted, be used, you know, whatever the person's particular circumstances. So this isn't exclusively for any one cohort of people. It is something that we can adapt to all and every, like, because all social care is all and every, isn't it? Is that a decent summary that that in my questions that have been going along?
Yeah.
Well, I'm going to give myself an A star for that. So that's wonderful. Thank you, everyone. Thank you ever so much. However, the real credit goes to yourselves. So thank you very much. If you're all happy, then what I will do is start to draw affairs to a close. Thank you very much to the panel. So Priti, Peter, Tom and Louise, thank you ever so much for joining us, and Steve in the background for running the technology. We really appreciate your time and hearing to your stories. Thank you for all the attendees. We really appreciate it, and I hope it's been of value to yourselves. What we're really keen for is to be able to showcase how the services and sector is working to find solutions to really thorny issues and coming together, and, you know, kind of bringing a bit of head, heart and humanity to all of those solutions that we find. But this only happens if you go away and think about it and talk about it with your colleagues, and it gets translated into real world differences. So let us know how you think you might go about doing something differently in your area, any brilliant ideas you're having, or any other developments you're making that you think we would be interesting, because we're really keen to not only learn ourselves but share the learning more broadly. We do have more of these webinars coming through, so the little slide on your screen, you can join up to our newsletter Skyline, which will allow you to register for the next one, which is on the 30th of June. We're going to keep these coming throughout the year, and they'll be on a wide range of topics. So we'll be looking at strengths-based approaches, we'll be looking at workforce issues, we'll be looking at co-production, we'll be looking at technology, and we'll also be looking to make sure that we've got the right package of different supports available for all of our different communities. So keep your eyes peeled for those that are coming through. If you'd like to leave us an evaluation, we would welcome all of your feedback, because everything we hear from you helps us learn and grow and keep meeting the needs. But thank you once again from our colleagues, and we hope to see you soon at our next webinar.
And so for the audience, there will be an evaluation when you sign off, but if you want to write some nice things in the question box, please do. I'll leave that open for a while. And panelists, to leave the webinar, it is file, exit, leave webinar. File, exit, leave webinar.
Thank you, everybody.
Thanks, everyone.
Thank you. Bye.